Hello, everyone. Thank you for joining us for the presentation entitled Employer Mandate and Measurement Period Starts Now. My name is Jenny Dodson, and I'm the Executive Program Manager for the Healthcare Reform Center and Policy Institute. I'm also the Assistant Editor for the National Healthcare Reform magazine. I'm here today to represent Jonathan Edelheit, who's the President of the Healthcare Reform Center and Policy Institute. Due to travel constraints, he was unable to be here, so I get to be here in his place and join all of you today. So I'm excited to be able to give the introductions and tell you a little bit about us before we roll into our update. So our webcast is at capacity. We still have a lot of you joining us, so welcome aboard. If you have questions or have any audio issues or just any questions that you have, there is a chat feature, a Q&A feature that you're able to type your questions right into the Q&A bar. So please do so, and we will answer those questions throughout the webcast. So as I was saying, I have the privilege today to be joined by one of our founding faculty, Ben Connolly, who's an employee benefits attorney at Saifar Shah. And he's given hundreds of presentations on PPACA legislation and many updates for us. And so we're excited to have him here. We also have branding partners with us today who are powering this presentation. And we welcome Main Street PowerMail to power this update. Just to give you some quick background, I know that in the interest of time we want to stay on task. So the Healthcare Reform Center and Policy Institute brings the Certified Healthcare Reform Specialist Program, as well as the Certified Healthcare Reform Professional Program to our students. And this program is essentially designed to provide education to agents, brokers, and consultants, as well as human resource executives that are looking for answers to the many questions that PPACA legislation has brought up for employee benefits. And our goal is to give that information and be the information highway for questions that you have. And so we offer this program, which offers quite a bit of information to our students, both from a searchability factor, from brand visibility. We offer the seal, which offers your the ability to have place our seal on your business cards or in your social media site. But I think more importantly, the benefits are, you can actually access the faculty and ask questions and have direct access. So we offer this in group setting, we offer this online, one-on-one, and we offer this in person at our annual conference, which this year will be held September 20th through the 24th, 2014 in Washington, D.C. So again, I'm so glad that you've joined us. I want to jump right into the presentation. If you have questions, don't hesitate to let us know, and we will answer them throughout the presentation. Just a quick flow, then we'll be presenting, then handing it over to our sponsors who are powering this event, which is Main Street PowerMail, and they will give you a brief presentation followed by the Q&A. The Q&A is a robust Q&A. I hope that you'll be able to stay and stick around for that, because I think you'll hear your peers and your colleagues asking questions that will really bring this presentation full circle. So with that, I would like to hand the presentation over to Benjamin Connolly, Employee Benefits Executive Compensation Attorney with Saifar Shah. And I will hand it over to you now, Ben.
At the outset, I just want to apologize. I usually try to dress up and wear a suit for these types of presentations, but being in Chicago, it was very, very cold this morning. So I focused on survival above style, so I hope you'll bear with me. Although I know you're not here to look at me, you're here to learn about healthcare reform. So let's jump right in, and we'll talk about where we're headed. Okay, so at the outset, we're going to start with a brief sample of how the measurement and stability period might look going into the 2015 calendar year. I know that there are a lot of different options there. The people on the call know that you have a lot of flexibility in terms of how you structure your measurement and stability period, and one size does not fit all in this regard. That being said, we are going to show you an example of what we view as one of the most popular structures for the measurement and stability period going into 2015, which might work for your organization. Then we're going to go into a guidance update and talk about some of the recent regulations that came out regarding accepted benefits. As is always the case at this time of the year, the regulators dropped a lot of information on us right before the holidays, so we're still parsing through some of that, and we want to share with you some of those updates now. Then finally, we're going to get into a discussion on some of the cutting-edge approaches we've seen employers taking towards addressing healthcare, or not addressing healthcare for that matter, because people are really starting to look at revamping their traditional benefit offerings in light of the changes that are taking place in the marketplace. I'll talk a little bit more about that. I don't want to indicate that it is the most prevalent approach to go with an alternative to traditional healthcare, because I think that what we've predominantly seen is that most people are taking a wait-and-see approach. In other words, they're sticking with their traditional benefits offerings now and, seeing how the market shakes out. That being said, we have seen some ideas brought to the table, and we'll discuss what some of those look like. So before we talk about the sample employer measurement stability period, let's talk about where we are today. So as we all know, the employer mandate was originally going to be effective 1/1/2014. The proposed regulations included a series of forms of transition relief, one of which was transition relief for employers sponsoring off-calendar plan years. And what that allowed you to do was essentially come into compliance at the start of your plan year, even if that was after 1/1/14. To be clear, that transition relief only applied for the 2014 calendar year. After that transition relief was issued, as we all know, right around the 4th of July, the IRS delayed the employer mandate across the board, meaning no one has to comply before January 1, 2015. Now, I think a common misconception that people are still relying on is that at present, they will not be subject to the employer mandate until the start of their plan year that begins on or after 1/1/2015. As the law presently exists, no transition relief exists that would allow you to extend or wait until after 1/1/2015 to start complying. Now, I don't mean to suggest that the IRS will not come out with subsequent transition relief that provides a similar delay, but at present there is nothing in the law that would provide you with that delay. Moreover, we've heard informal comments from Treasury officials that suggest that the whole idea behind that transition relief was that people didn't know what the rules were and they needed more time to come into compliance. Well, now everybody has more time to come into compliance because everybody has until 1/1/2015. So the suggestion, at least from the Treasury officials, was that we should not expect that all forms of transition relief will be extended across the board. So that's where we stand in terms of effective date. Long-winded way of saying 1/1/2015 for everyone until we hear otherwise. Again, this rule only applies to large employers, generally 50 or more lives, and the rule generally requires that employers offer coverage to full-time employees. Now, there are two ways to do this. The first way you can do this is look on a month-by-month basis. But because of the difficulty associated with that approach, the IRS came out with a safe harbor of sorts that allow employers to measure over a longer period of time, known as the measurement period. And then the back end of that bargain is that you then must continue coverage during a subsequent stability period that is generally the same length of the measurement period. So the way that this would work is that 2015 would be the initial stability period, because the stability period is when coverage begins, and coverage has to be offered 1/1/2015. Again, just to be clear on that point, the measurement period does not start 1/1/2015. There is a measurement period in 2015, but that's for 2016 coverage. The measurement period for 2015 coverage is likely now. In other words, we are in the first measurement period, and the first stability period will be 1/1/2015. A few broad rules about the way the measurement stability period safe harbor works. Generally speaking, the measurement period, the length is the employer's choice, and it can be between 3 months and 12 months in length, and then it must be followed by a subsequent stability period. The stability period must be at least 6 months long, but can be no shorter than the measurement period. So generally, the two will be the same length unless you have chosen a measurement period that is less than 6 months. Finally, you can also take advantage of something known as an administrative period. And an administrative period is a period during which you are processing the data that you've accumulated. So looking at the numbers, seeing who is full-time, who is not full-time, and deciding who to offer coverage. Now, one of the biggest questions we always come across is, well, how do I count these hours? The IRS has come up with its own rules in terms of how you're counting hours. In other words, they've defined the rules for how you're counting hours. They have defined what hours need to be counted. There's a possibility that your payroll system already does this, but the likelihood is that even if you have a payroll system that is tracking hours, that's perhaps not tracking the types of hours you need, or in the manner that you need it to be tracked for purposes of the measurement and stability period safe harbor. So a lot of people are looking for outside solutions. I know that there are vendors coming to the market creating solutions. One of the ones that we've worked with is a company known as WorksTime, which has created software that is specifically catered to this rule. In other words, it input all the data in terms of what the IRS says you need to count, and then it spits out who you need to offer coverage to. We'll talk a little bit more about that in advance, and I don't mean to indicate that that's the only vendor out there, but that's one of the ones that we've worked with closely. We know their software and know that it works well. So those are the three components of the safe harbor, the measurement stability period safe harbor. So with this in mind, let's talk about how it works. So again, what we want to propose here is simply a sample measurement and stability period safe harbor. In other words, you get to choose the start date, the end date, you get to choose the length, but this is one of the recommendations we've come up with for employers that have calendar year plan years, because this is what we find to be the most administratively convenient. So the first one we want to talk about is the measurement and stability period for existing employees. So this is for your workforce that is there today and excludes new hires going forward. We'll talk about how to address new hires going forward, but this is where we start. So generally speaking, for a calendar year plan, the easiest way to go is a 12-month measurement period. The reason why is that then you would have an associated 12-month stability period, which would correspond directly with the plan year. And let's start with that piece. So bumping down to the bottom of this graphic, the easiest stability period to go with is your plan year, January 1 to December 31, because then you're not going to need to worry about shuffling people on and off of coverage mid-plan year. You can simply align this with your otherwise applicable enrollment platform. So backing up then, that's where we get to our recommendation on the other dates. In order to have a calendar year plan year, you have to have a measurement period that ends before the start of that stability period, obviously. Now, the key here is that if your measurement period ends too close to the beginning of your plan year, you may not have sufficient time to run the numbers and find out who is eligible, and most importantly, hold open enrollment so that those folks who are eligible have the opportunity to elect coverage. So what we've actually recommended is backing up the measurement period a little bit so that it doesn't align with the calendar year directly. In fact, it runs from November 1st through October 31st every year. And what that means is that your measurement period is ending 2 months before the start of the plan year, and the intervening period would be the administrative period. So again, you are permitted to have an administrative period in between the two as long as it does not exceed 90 days in length. So here we've suggested the administrative period running from November 1st, which is just after the measurement period ends, through December 31st. So a 2-month window there. Now you can back it up if you want, and you can actually use a almost 3-month window, but not quite. And the reason I say not quite is because 3 months is slightly more than 90 days, and what we know is that the administrative period cannot exceed 90 days. So an October 1 start date to your administrative period would actually result in an administrative period of 91 or 92 days. I'm not sure exactly which it would be. I think it's 92 days. And that's a little bit too long. So, you know, you can either do it up until October 15th or October 31st, and that gives you that time period then, that 2-month window to hold the administrative period. Now, the open enrollment, you can really have that whenever you want during that administrative period. What we've looked at from a number of our clients is that they quite often have a 2-week or 3-week open enrollment period, maybe even a month, and you just want to put that at some point in that administrative period. Probably not right at the start of the administrative period, because you're going to need at least a week, maybe 2 weeks, maybe even a month to determine who is eligible to even enroll during that open enrollment period. So we've thrown out sample dates here of November 1st, 18th through December 19th, which gives you time on the front end, gives you a nice long open enrollment window, gives you time on the front end to add up hours, and it gives you time on the back end to process the participant elections. All right, so now let's talk about new hires, because the rules are totally different for new hires. Generally speaking, new hires fall into 2 categories. You either have full-time new hires, which are people you know based on facts and circumstances must be offered coverage as of the date of hire. I'm sorry, not as of the date of hire, within 3 months of their hire date. So if you hire somebody and they are clearly full-time, you have to give them coverage or offer them coverage within 3 months. Everybody else falls into this category of variable hour employee. We're not going to dig into too many details about how you distinguish between the two, because that's the subject of an entirely different session. But That's generally the distinction between the two. So variable hour employees, the significance there is that you can measure them over a significantly longer period of time. In fact, you can measure them for up to 12 months. You can also build in an administrative period of up to 90 days, but the measurement period plus administrative period combined can never result in the delay of coverage to an otherwise eligible individual of more than 13 months following the first of the month following date of hire. So what you're really talking about there is they have to get coverage within 13 months and change, almost up to 14 months depending on their date of hire. So what we've proposed here is actually what we think is a little bit more administratively convenient, because if you just start the measurement period on date of hire for everyone, you could potentially have 365 measurement periods going on in any given year. So what we've proposed is splitting the administrative period into two pieces. One piece before the measurement period and one piece after the measurement period. So the way that it would work is any given new hire, their measurement period doesn't start until the first of the month following or coinciding with the date of hire. That means now you only have 12 measurement periods rather than 365. You then have the 12-month measurement period that begins the first of the month following or coinciding with the date of hire. And then at the end, you still have a little bit of time left over, so you can have a 1-month administrative period following the close of the measurement period, during which you determine whether they're eligible for coverage and allow them to make the election. And then you have the associated 12-month stability period that follows on the back end, because the measurement period and the stability period must be the same length of time. So a lot of charts here. Let me show you how it works visually. So again, we're starting here with your rank and file employees, not your new hires. The measurement period would start, and this should actually run out to the left a little bit. This would start back at the beginning of November 2013. Remember, we're looking with an eye towards getting coverage effective 1/1/2015. It starts in 2013, runs through the end of October 2014. Then you have an associated administrative period. And then you have the stability period that runs from 2015 to 2016. So that's the way it's going to work for your average employee. Now, in any given year, you are both providing coverage in 2015, but also measuring to see who gets coverage in 2016. So it's always overlapping. It's a cycle. And one thing the rules have said is that if you use an administrative period, it can never result in a break of coverage for people who are otherwise eligible. So your stability periods always have to run into each other. Now what that means, let me just roll everything out here and then I'll talk about what we're looking at. What that means is that you're going to have the measurement period overlap with the administrative period so that you don't have a break in coverage. So stability period must always flow into stability period, and measurement period must always flow directly into measurement period. You're just going to have a small overlap there with where the administrative period overlaps with both the measurement period and I guess the stability period for that matter. So again, we're looking at 2015 here. Let's assume we've already measured, right, in 2014. People get coverage in 2015 if they were eligible. At the same time during 2015 you're measuring, though, to see who gets coverage in 2016. At the same time during 2016 you're measuring to see who gets coverage in 2017, and so on and so on. It's an endless cycle. Brief illustration here of how this would work for variable hour new hires. Again, let's take an example here of somebody who was hired February 15th. Now remember, in our proposal, the measurement period would actually start the first of the month following date of hire, which would be March 1, 2014. It would run through February 28th, 2015. If the person qualified for, and then you can tack an administrative period on the end, which would run from March 1, 2015 to March 31st, 2015. If they qualified for coverage, their stability period would start April 1st, 2015 and must run for a year. Now, eventually you're going to have to switch all of your new hires up onto the track that is consistent with your ongoing employees, which remember is a November through October measurement period and a calendar year stability period. So the way that that would look is, as you're measuring this person as a new hire, eventually you are going to simultaneously start measuring them as an ongoing employee. So they're in two measurement cycles right now. One is a new hire to determine whether they get coverage April 1, and another is an ongoing employee to see whether they get coverage in the subsequent year, which here would be 2017. A little bit confusing, I know, but that's the general concept is eventually all new hires must be switched over onto the ongoing employee track. And that first year of hire is going to be where you see the overlap. Okay, so that's the sample. Again, we'll take a couple questions in a bit, and we'll talk about how that works to the extent anybody needs clarification. But now I want to move on to some new guidance. So healthcare reform creates a concept of something known as a group health plan and an accepted benefit. A group health plan is an employer-sponsored plan that constitutes minimum essential coverage. Minimum essential coverage is a significant term because it is what employers must offer partially to avoid a penalty, and is what individuals must obtain to avoid a penalty. Backing up a second, you get these concepts of group health plans, which is like medical coverage, and then accepted benefits, which is like a standalone dental and vision plan. Group health plan, medical coverage or group health plan would constitute minimum essential coverage and would satisfy the individual's obligation under the individual mandate, whereas an accepted benefit would not. In other words, if you go purchase an accepted benefit, you have not satisfied your obligation under the individual mandate. So this is significant because the IRS doesn't really want people to be disqualified for tax credits on the exchange because they enrolled in something that they didn't think would disqualify them but actually does. And the IRS doesn't want people to skirt the system by, rather than getting actual health coverage, buy something that is less than health coverage and be considered to have satisfied their obligation. So there are these old rules under HIPAA that define what is a group health plan and what is an accepted benefit. And they didn't really take into consideration this whole new structure that we have today under healthcare reform. So what the IRS did in late December was go back and tweak the rules so that they can slot certain things into the accepted benefit category. And what that means is that enrolling in that benefit will not make you ineligible for a tax credit on the exchanges. So they talked about three benefits in particular. The first was standalone dental and vision coverage. So dental and vision coverage will generally be considered an accepted benefit if it is either offered under a separate insurance policy from the medical coverage if it is a fully insured benefit, or if it is a self-funded benefit, if the plan sponsor offers both a separate election and requires a payment of a separate premium in order for that individual to obtain that coverage. So it's sort of unbundled election rights from the medical plan. In other words, you don't just get both in tandem. They're not bundled together. They're broken apart. So what a lot of people said was, this is a little ridiculous. We were offering this dental coverage, and we're actually offering it for free to our employees. But now you're telling us that a host of obligations attached to that coverage, because it is bundled and it's being offered for free, we're just going to start assessing a premium of, let's say, 1 cent a year to get around this stupid requirement. I'm summarizing there, obviously. So the agencies came out and said, we agree. We've heard what you said. We agree. And in order for dental and vision coverage to be considered standalone, we are now removing that separate premium requirement. In other words, if you have a dental or vision offering, as long as employees can opt out of that coverage if they want to, it will be considered a standalone benefit. But there is no requirement that a separate premium be assessed in order for that to be a standalone benefit. So that's the first big one. Now this has flow-through significance for employers because if you have a group health plan, it's subject to all the insurance mandates under healthcare reform, the adult child coverage requirement, the prohibition on lifetime and annual dollar limits, et cetera, et cetera, et cetera. So this broadens what would be considered an accepted benefit, meaning it broadens the category of benefits that are exempt from these types of mandates. The second change came to EAPs, or employee assistance plans. Previously, the standard was pretty broad in terms of whether an EAP constituted a group health plan, and that was that if it provided significant benefits in the nature of medical care or treatment, it would be considered a group health plan. Now, the reason why this is significant is because many employers offer an employee assistance program that is very broad, and in fact, much broader than the medical coverage. In other words, medical is usually limited to a discrete population within the organization, let's say full-time employees. But EAP is available to anybody who works there, or anybody really who has that dial-in number that can dial in and call the EAP counselor. The reason why that is significant is because if the EAP itself is a group health plan, then it's subject to a host of additional requirements. For instance, that EAP must offer preventive care services at 100%. EAPs simply aren't meant to be that vehicle. So the IRS came out and tweaked the definition of whether an EAP is a group health plan, And what that allows employers to do is continue offering those benefits separately and not have to worry about complying with those requirements. In addition, employees don't have to worry about the fact that they might have been defaulted into an EAP, which now renders them ineligible for a tax credit on the exchange. Because even though the EAP is not supposed to be medical coverage, there is this chance, I guess, that if your employer is offering it and you're automatically enrolled in it, you could be rendered ineligible. So that's where we stand on EAP. So let's talk about how that definition changed. Under the new guidance, EAPs are still accepted benefits if they don't provide significant benefits in the nature of medical care or treatment. But here's the definition of significant. Specifically, EAP must provide less than 10 outpatient visits annually. It is allowed to provide an annual wellness checkup, and it can provide immunization and diabetes counseling, but it cannot provide inpatient services for those benefits. Further, there can't be any premium or contribution assessed for that benefit, the EAP, so no employee payment for that benefit. The benefit, the EAP, cannot coordinate directly with the medical plan. In other words, if the medical plan provides some sort of mental health services, those must be provided without regard to what the EAP is providing. There can't be any participant cost sharing associated with the EAP. Let me say one more thing about that. Another reason why this is significant is because when people were calculating their liability under the PCORI tax, you were required to calculate that based on the broadest reaching group health plan that you offered. As I mentioned, medical plan coverage or enrollment is often, quite often significantly more limited than EAP coverage. So for many companies, and especially large companies, this might significantly reduce their liability under the PCORI fee. Now, the transitional reinsurance program fee is the bigger fee, and the standard there was actually a little bit different. So this rule doesn't have necessarily the same impact there. And in many instances, in fact, the transitional reinsurance program fee excludes EAPs, even if they go beyond what this definition is. So again, it does have significance for the PCORI fee. You need to separately analyze whether it has significance for the transitional reinsurance program fee. Okay, and then the final one that came out was something, was a new accepted benefit that was created under healthcare reform. And to provide a little background here, I think that the significance is there was a big push in the multi-employer plan community for multi-employer plans to be able to split off their subsidy-eligible employees and send them to the exchange. And in order for the multi-employer plan to continue to provide some sort of benefit to that individual, the multi-employer plan would provide sort of top-up coverage. So you're buying a bronze or silver package on the exchange. The multi-employer plan is layering on top of that and providing supplemental benefits like dental benefits, out-of-network claims, vision coverage, orthodontia, et cetera, et cetera, et cetera. So that was the clamoring, was if employees are going to the exchanges, I want to be able to offer them something that makes them have a better benefit and not just not lose my touch with that individual entirely. So that's the idea of this new accepted benefit for a wraparound plan. And what the regulator said was that if you meet these certain criteria, which we're going to talk about, they're pretty onerous, and you offer this type of supplemental wraparound coverage, that will be considered an accepted benefit, and you won't be subject to the host of other requirements that might attach to that coverage. Now, the devil is in the details here, because what we found out was that the conditions that you must meet for a wraparound plan to qualify as an accepted benefit are actually rather onerous. Specifically, it must wrap on an individual non-grandfathered insurance policy. So what we're talking about there is coverage in the exchanges, really. The primary purpose of that wraparound plan cannot be reimbursement of the exchange plan cost sharing. In other words, they don't just want you to be picking up participant out-of-pocket costs on the exchanges. They want you to be supplementing that coverage that's offered under the exchanges. If there is some element of reimbursement of cost sharing there, that's usually all right, but it can't be the primary purpose. Further, in order to be even eligible to offer this wraparound coverage and have it stand as an accepted benefit, you as the employer must offer traditional medical plan coverage or core coverage to your employees, and it must provide minimum value, and it must be affordable for the majority of your employees. So this cannot be an alternative to employer-sponsored coverage. This can only be in addition to employer-sponsored coverage. And in fact, most of your employees must be eligible for affordable minimum value employer-sponsored coverage. So the idea here from the regulators is, we understand that you're going to set your premium at a certain point, We understand that coverage will be unaffordable for people below that point. As long as that population for whom coverage is unaffordable is less than half of the employees, we're going to allow you to help out those people for whom coverage is affordable and that go to the exchange. So, in other words, it's attaching to that group and running with them. And that's not all. We have some more conditions as well. The coverage must only be available to employees eligible for the primary medical plan. So again, they're trying to discourage employers from using this as an alternative to a traditional coverage. The total value of the wrap coverage can't exceed 15% of your traditional medical coverage, the employer's traditional medical coverage. And what we mean there is the COBRA rate, can't exceed 15% of the COBRA rate. And most importantly, the wraparound coverage can't discriminate in terms of eligibility, benefits, health status, or compensation. I know that a lot of folks have started looking at this model where they say, all right, we're going to identify our sick employees, and they're still eligible for our health plan, but we're going to incentivize them to go to the exchange because we're going to offer them essentially zero cost sharing on the exchange. So when you look at this wraparound plan, accepted benefits guidance, what you see here is that the IRS is familiar with that strategy, and what they're saying is there are ways to do this. There are ways to top up coverage on the exchanges, but we don't want you to use this as a vehicle just to send your sick employees there. So that's where we stand currently on the wraparound plan coverage. All right, I know I only have about 5 minutes here, so I'm going to run through quickly a couple alternatives to traditional employer-sponsored coverage. No extended discussion of these pieces, but I just wanted to throw these out there to give you a heads up. So a lot of people are talking about private exchanges. This is primarily for employers that are too large for the federal or state exchanges, but they work the same way. In other words, employees go and they have a menu of options. They can be either self-funded or fully insured under the current models that we've seen. But what it really is benefits outsourcing. We've seen that this is not really new in any respect. All it really does is create more options for your employees. Now, query whether that's a good thing. If all employees were effective consumers of health care, that would be fantastic. But what we found is that this can also often result in election freeze, where you have too many choices and you can't make up your mind. Another approach we've seen is something known as the skinny plan. And we're not saying skinny here in the context of Jillian from Biggest Loser. We're talking about skinny in the concept of narrow reach. In other words, this is a plan that only offers preventive services, and it would constitute minimum essential coverage. The idea here being that large, fully insured and self-funded plans don't have to offer a menu of benefits. They can offer whatever they want. The one benefit they do have to offer is preventive services. So you could offer to your employees a preventive-only plan and partially satisfy your own obligation on the employer mandate. The problem is that that plan likely wouldn't provide minimum value. So while you avoided the big penalty under the employer mandate, you still might be subject to the small penalty for employees who opt out and go to the exchanges. A lot of people are looking at adding simply a minimum value option, and this would be a option that satisfies the obligations of the employer mandate. So what you've got is maybe your HMO and your PPO, and you're adding another tier below that, maybe a high deductible health plan that fills that bottom slot there. Other people are also looking at tiered premium contribution requirements. So while you cannot discriminate in favor of highly compensated employees, you can always discriminate in favor of lower compensated employees. So because from an affordability perspective, you must limit the employee premium for self-only coverage to 9.5% of income, many people are saying let's link it to 9.5% of income. You're going to pay 9.5% of your income towards the cost of coverage, and that's all you're required to pay, which satisfies the affordability obligation, but allows you to scale up and charge more as employees start making more. A lot of folks are also looking at something known as the efficient frontier, or premium optimization. The idea here is that there might be a win-win situation. In other words, it might be a situation in which it's cheaper for the employer to pay the penalty for an individual, and that individual might actually be better off at the exchange because they can go to the exchange and get a tax credit and actually pay less money than they would pay under the employer's plan. And the employer's winning as well because they're paying a penalty for that individual, but the penalty is less than they would pay for that individual's coverage. I've heard anecdotally that the key level here is 250% of the federal poverty level, so below that level, it might make sense to set up a structure whereby that coverage is unaffordable for those individuals. Again, you're not charging more. You're just setting the premium, so everybody falling below this line, it's unaffordable. And then those individuals have the option to go to the exchange, which could be a win-win. Often, a lot of people are talking about getting out of the healthcare game entirely, paying the penalty, and giving a lump sum cash contribution for the remainder of whatever the employer would be paying to employees. You have to be careful here. It must be taxable under recent IRS guidance, but you can always give people more money. Perhaps your employees would be happy. Perhaps, though, they want that health care coverage. And remember, now they have to get health care coverage, so they would have to go to the exchange for that coverage. And let me just make sure. Oh, yeah, we're almost through here. A lot of people are also looking at workforce management. They're either readjusting their health plan eligibility levels so that they are going from 32 or 35 hours a week to 30 hours a week so they align with the employer mandate, or they're considering actually limiting employees' hours to 29 hours a week so nobody qualifies for coverage. There is some risk with that approach. A detailed discussion is beyond the scope of this webinar, but just be cautious that ERISA in some instances limits your ability to do that. So you want to make sure to check with your legal counsel before you take that approach. The wraparound option, again, we talked about that ad nauseum, but that's another thing that employers might consider. And then the final option is really just tweaking the way that you're offering employer-sponsored coverage. And this is like GLE and Biggest Loser, where you're telling your employees, we want you to have some skin in the game. We want you to live healthier lifestyles so that our medical costs go down across the board. And we see a number of ways that people make this happen. Consumer-driven healthcare, where you have like a high-deductible health plan, where employees are actually paying more when they go to the doctor, so they're incentivized to be smart about their health decisions. Wellness programs, where you derive employee behavior and hopefully bring down health costs. And then the final two, which have been around for a while but are helpful, are health advocates, which are individuals who help people navigate the healthcare system, and then health coaches, which are individuals who work with your high-cost chronic condition individuals and make sure that they're getting the right kind of care. So happy to take some questions in a moment, but at this point, I would like to introduce our branding partners, Callie Smith and Amy Huntsman, with Main Street PowerMail. Main Street PowerMail will lead the Q&A session and will moderate questions from today's presentation. So with that, I'm passing it over.
Hi, everyone. Thank you, Ben. Just like to introduce myself. I'm Callie Smith, Director of Outside Sales for Main Street PowerMail. We're located right outside of Indianapolis in Sheridan, Indiana, and our company has been around for almost 13 years and has made strides in the lead industry for agents and brokers all across the nation. So give you a little information on what we do. We specialize in direct mail-outs for the senior market. So we have pieces for final expense, turning 65, Medicare, MedSup, and annuities, just to name a few. And our system, we've made it very easy for everyone to use in assisting you in making money, which is our main goal here at Main Street PowerMail. Whether you're an agent wanting to sell or you're a broker with agents, you're going to be able to keep track of it with our system and help maintain them all. We have a great team that can also help out with the mailers in your area, and if you have in-house pieces, we can use those, or if you want a custom piece, we can also help develop that too. Our in-house design team helps you pick out the best piece for your goals. To help with your peace of mind, we can also give you an idea of what percentages you'll be getting back in almost any area so you're aware of your potential results before you send out any pieces or do any business with us. And when they start returning, we scan them in digitally. You can access them the same day on your account, and you send hard copies once a week so that you can have both in your system. This helps you keep track of your areas and percentages. If you're a broker, you can see what all your agents are doing and their results as well. Our main goal at Main Street PowerMail is we want to make you money, and we do that by getting solid leads for you to sell to. So we assist you with everything along the way, and our company is always in contact with our customers. So you will always reach a person at Main Street PowerMail. No voice recording or computer electronics going on. So we value your business, and we always want you to feel that way. Our customers know that we love them and really appreciate them. They love using our service because they know they will get leads back. Some of our customers have quoted us as the easiest leads company to work with. And one of our favorites here, most recently, Mr. Troy Underwood of Benefits Connect bragged about our in-house design team and how quickly we were able to do a custom piece of such high quality for him and his company. And our customers know we are here to make them money and get the leads they want every time they use our service. So something we've put together for a few of the brokers, and I'll make sure that it's popped up here, is how you can make an extra additional $100,000 a year.
We've had a lot of people that have loved it. It's been a great success, and now we have it up on our website to inform agents on how to make extra money. It's very simple. You just plug in what amount of leads you want, and it will give you an idea of how much you can make a year. And I'm sure most everyone wouldn't object to an extra $100,000. I know I sure wouldn't, and for those brokers, I know your agents sure wouldn't either. If you haven't already, I want to make sure to direct everybody to visit our website at mspowermail.com and like us on Facebook. And if you'd like any more information, I want everyone to please feel free to contact me, Callie Smith, or Amy Huntsman, and we'll be happy to assist with any questions you have and help you out, send you some mailers, different pieces we have. We can give you some examples. And I just want to thank you for letting me take up some of your time today, and of course want to thank everyone for joining us. It's been a pleasure speaking about Main Street PowerMail. Thanks for listening. And at this time, I would like to begin with the questions anyone of the panelists may have and introduce Ms. Amy Huntsman to moderate that.
Hi, Callie. Thank you very much. Does anyone have a question for anybody? The one that I had is it was more along the lines of what are the risks if we do not track hours within our companies? I was hoping Ben could answer that for me.
Absolutely. So it's important to keep in mind that this is not just a self-administered program. So, under many other requirements under healthcare reform, you just hope that the DOL doesn't come in and audit you. This is one, in fact, where there is a direct IRS every year telling how many hours people worked, who was full-time, who was not full-time. So there will be a requirement to be able to demonstrate either directly on these reports, we don't have the final format yet, or upon IRS audit, who actually is full-time. So it's going to be important to be able to track those hours. As we mentioned, there's a lot of software out there. WorksTime is one that we've worked with directly, but there are other vendors as well. So it's important to find a software that works well with your organization, works well with your current payroll practices, and will provide you with easy to understand reports demonstrating who you need to offer coverage to and providing you with that backup that you need in the event that it's either required on the IRS report or in the event of an IRS audit. So, oh, and by the way, the penalties are pretty big for messing it up to and including $2,000 multiplied by all of your full-time employees. So it can be pretty significant. So great question.
When are you expecting the IRS to issue these final regulations?
That's also a really good question. Unfortunately, I keep telling people it's right around the corner, and it just hasn't happened yet. That being said, I've heard it from the mouth of the horse. In late November, we heard from the IRS, a very higher up Treasury official, who was quoted in an article as saying they're going to come out any time now, probably before the end of the year. That came and went, and nothing happened. I like to think that that was probably as a result of the shutdown, but it's hard to say specifically. Just within the last 2 weeks, there was another Treasury blog post that suggested that the regulations are going to be released, quote unquote, shortly. Again, it's got to come soon because otherwise they're going to need to build in additional transition relief because people are going to be clamoring for the ability to adjust accordingly. But we have to imagine it's going to be within the next month.
And my last question, sorry, what approach do you see that most businesses are leaning towards? You've offered many different options.
That's a great question. I would say at the time being that the vast majority of folks are continuing on with their traditional benefit offerings. Obviously, consumer-driven healthcare is a big thing, and people are looking at controlling costs. But most of the clients that I work with have exercised an abundance of caution in terms of just jumping ship and moving to another structure entirely, because for a number of reasons. One, we don't know how the exchanges are going to work. I know the small business exchanges, the online enrollment for that process has been pushed out an entire year. Private exchanges are great in concept, but I've heard informally that people are actually seeing greater cost acceleration under private exchanges than they were seeing off the private exchanges. And remember, private exchanges aren't really anything new. It's just a repackaging of an existing system. So I think that for the time being, and I'm not trying to say that this will be a long-term trend, but for the time being, it appears the vast majority of clients that we work with are continuing through traditional benefit offerings while re-examining alternatives. I know there are stories out there to the contrary. I know there was a big announcement from a major retailer last week that they're dropping coverage for part-timers, but I think that those stories at present are making more of a splash than anything else, but not necessarily indicative of the broader trend.
There is a question from one of the panelists asking you to clarify if a larger employer offers a group plan and the employee is eligible and the plan has premium required that is less than 9.5% of their income, that person cannot be eligible for the subsidy and cannot get the wraparound plan. Is that true?
Well, that's right. I mean, that's exactly right. Is if the employer has already offered affordable coverage, employees simply won't qualify for a subsidy on the exchanges. So the wraparound is really, at least the way the regulators have envisioned it, it is really an opportunity to supplement coverage for employees that you have offered minimum value coverage to, but for whom that coverage is unaffordable. So that population that has unaffordable coverage through your plan is now going to the exchanges, and you can give them a little something extra. Great question, though.
And we have another one that says this person has a small group with quite a few part-time employees. Then the owner decided to increase their hours to over 30. Can they add these employees as a qualifying event?
If the employees' hours have increased, and I might be misunderstanding the fact pattern here, so correct me if I've gone off course, but if the employees' hours have increased and the employees are now eligible for health insurance coverage, that is absolutely a qualifying event that would allow them to make a mid-year election to enroll in that plan.
Thank you. I think that's exactly where the question was headed. Have you seen the 105 reimbursement plans being marketed by Zane Health? They claim it is not limited to the recent technical release for HRAs.
You know, I don't want to speak to any model marketed by any specific individual, but I do know, or any specific company, but I do know that there's been a big push over the last 2 years to provide some sort of defined contribution type of health care, where you're essentially providing a reimbursement model where you're reimbursing employees either for premiums or for health care costs outside of your plan. What I can say is that the IRS and the DOL have made clear all along that they don't like that approach. And then they made it abundantly clear late last year that those types of reimbursement models don't work. In other words, the IRS does not want there to be a circumstance in which you are shifting your employees off to the health insurance exchanges but allowing them to pay for that coverage on a pre-tax basis or being reimbursed for out-of-pocket expenses on a pre-tax basis. What I will say is that there are innovative and creative people that find loopholes in any law. But what we've seen consistently here is that every loophole that has been created, the IRS has subsequently shut down. So again, I can't speak to any specific model, but I would approach any such model with skepticism because the IRS's opinion in this regard has been made abundantly clear.
Thank you. The IRS does like to close loopholes, don't they? Another panelist wants to know, how do you get around charging everyone 9.5%? Question for 2015 is how they define these job classifications. For example, 2 employees do the exact same job and one makes $10 an hour and the other makes $10.50 an hour simply because they have not been employed, or they have been employed a year longer. If the employer charges both of these employees 9.5% of their wages for health insurance contribution, there would be a discrimination between them because they are similarly situated employees being charged 2 different rates for the same benefit coverage. Absent plan rules that, absent plan rules that explain the distinction, this difference in contributions would be discriminatory and arguably impermissible under IRSA.
Well, that's a mouthful, but I can give my 2 cents on that, I guess. I'm not quite sure the distinction in the $10 versus $10.50, but what I will say is that there absolutely is a prohibition. It's not under ERISA, but it's under the Internal Revenue Code on charging or giving preferential rates or preferential treatment to highly compensated employees. there is no such distinction for lower compensated employees. The other thing is that there is the rule under HIPAA that you cannot discriminate based on health status. But the proposal of linking premiums to income does not discriminate in either respect for two reasons. One is that if it's 9.5% of your income, lower compensated people are going to be paying less. That's perfectly acceptable in the eyes of the IRS, and a number of our clients have been doing that for years. Albeit not directly linked to income, but perhaps tiers. Below this rate you pay more, above this rate you pay, et cetera. And it doesn't discriminate based on health status because it's the amount charged is irregardless of health status. So I don't necessarily see a problem with that approach under any of the applicable laws.
Okay, it looks like that's all of our questions. I'd like to thank everyone for joining us today. Ben, you're very informed, and we really appreciate that. Thank you. To connect with any one panelist after today's presentation, please call or email for our contact information from the slides. Thank you all. Oh, wait, I do have one more question if you're still there. What happens if an employee in the stability period has no hours for weeks at a time, but they are still active employees? Can an employer terminate the employee? And if so, is there a time frame that should be followed, or should they invoice the employee for their share of the contribution?
That's a great question. So coverage, if somebody qualifies for coverage during the stability period, that coverage must continue regardless of how few hours they work. That being said, if they have a break in service, which is generally defined as a period of no active, even though you're an active employee, a period in which you're working no hours, generally you can terminate coverage, and that depends on what your plan says. But the IRS has very specific rules in terms of looking at the length of breaks of service and the length of time in which you work before that break of service, and determining what happens when they come back. So when they start working again, do they come back into the same stability period? Do they start a new measurement period? How does that work? Again, beyond the scope of this discussion, because we've got an entirely separate presentation specifically on the break and service rules. But if your plan says your coverage terminates at the end of the month in which you have a break in service, then you can proceed accordingly in that regard.
That looks like the last of the questions. Questions again, you can contact any one of us regarding our sponsor and or regarding the program and or regarding the mandate, and any questions you have for Ben. Ben, thank you again for joining us, and Kelly and Amy, thank you so much for moderating and sharing information about Main Street. We are really, really thankful for your powering our webcast, and wish everybody a great afternoon. And we will be emailing the presentation within 2 to 3 business days. So thanks all.